So this question will be started from, this question will be discussed from Dr. Ikra.
Yes, ma'am.
Yeah.
Color of discharge from ductal papilloma. Red, ma'am. Option A.
Color of discharge from ductal papilloma, why not green and creamy and green? Because this greenish will be the ductal ectasia, right? And red
Yes.
will be for the papilloma and purulent for the mastitis. Okay, doctor, thank you. It will be the red color. Thank you, dear.
Thank you, ma'am.
Question 2 will be discussed with me, Dr. Saba Jisan.
A female patient with red pupil discharge mammography showed intraductal papilloma. What is the best next step? Mm, Ma'am, core biopsy or true cut biopsy?
Only one. You can give only one. Red nipple discharge mammography show intraductal papilloma. My dear, if you do wrong, I am very hurt, really. There's intraductal
Ma'am,
papilloma.
core
Your question, right?
biopsy is also intraductal
Intraductal
papilloma. What is the
papilloma,
best
sir.
next step? Yes,
Yes.
answer is A. Core biopsy, which is also called true cut biopsy.
Why intraductal papilloma, my dear? If they say intraductal papilloma, why we will do? Already they said, right? The mammography show papilloma, so we have to do excision, right? Ductal
Mm,
excision. We have to do the ductal excision. Okay.
okay.
So answer is C. It's a
C.
ductal excision. We have to do the ductal excision. This is wide local excision or ductal excisional, right? Because already interductal papilloma they discovered there's nothing. If they say interductal papilloma, why will do core biopsy? If it is mass, okay,
Okay,
if
ma'am.
it is mass lesion,
Okay, ma'am.
if there is anything, so we have to do the core
Ductal
biopsy.
excision.
Yeah. Yeah, here we have to
Okay.
do the ductal excision. Yeah. So see, we have to do the ductal excision and diagnostic and therapeutic purpose. So diagnostic and therapeutic purpose, ductogram identify the course of nipple discharge, and ductal excision we have to do the ductal excision. Okay, clear?
Okay. Clear, ma'am.
Why they must see it's answer is C, ductal excision. I think this writing is it should be the C, okay, because the C the explanation diagnostic and therapeutic were ductal excision. So ductal excision we have to do in next step. Okay,
Okay.
so next question will be discussed with me, Dr. Kishori.
Yeah, I'm here.
Yeah.
22 years old, came for regular visit, breast exam normal. She told you that she has been breast pain 3 days before every cycle. What to advise her? This she has been breast pain 3 days. This is premenstrual symptoms. 22 year old for regular breast exam normal. Ma'am, reassurance.
Actually, what to advise her? This question, my dear Kishori, two way they ask in exam. Okay, DHA exam question,
Mhm.
common question. If they didn't give clue for ultrasound, they didn't do anyway, they didn't do any time ultrasound. We have to do first bilateral ultrasound to ensure is there any problem present or not, any pathology present or not. Though we are understanding it's nothing to be worried, it's reassuring. But to advise our bilateral breast ultrasound, we can advise. You are a doctor, I am your patient. I am telling this presentation, I have pain in breast in 3 days before menstruation, and you have to tell, so you may need ultrasound, but you will reassuring me it's nothing, it's a physiological. But what to advise her, they ask, what to advise her most, you have to do, you have to advise me bilateral breast ultrasound. Okay,
Okay, ma'am.
so reassurance question will be if ultrasound done before. Okay, if ultrasound
Oh, okay,
done
okay.
before, okay, then we have to do the reassurance.
Okay, ma'am.
Okay, This question answer will be given by Dr. It's Dr. Sachma.
Yes, ma'am. Young female patient with clear bilateral breast discharge, what is otherwise normal? If she is otherwise normal, what will you do? A. Mammography. B. Ultrasound. C. Prolactin level and MRI. It's a clear bilateral breast discharge. She is otherwise normal. Will it's clear discharge. We'll do ultrasound.
Ultrasound. Cause why? Cause it's a clear discharge, right? Even
Yes.
if they give any discharge color greenish or reddish, we have to do mammography. Another point, Dr. Sachma, this question they ask another way. For example, if it is more than 45-year-old, okay, or more than 50, we have to do what, Dr. Sachma? If I say
Mammography.
it's a mammography, yeah. If it is mammography, if age more than 45, ultrasound initially, okay, but they didn't give any age value, so we have to do initially ultrasound. Excellent, done. Okay. So imaging test already I discussed that when I'll do ultrasound less than 35 or pregnant, mammography I already discussed these topics. This question also discussed just for ensuring that my candidates are hearing or not. This question will be answered by Dr. Munir.
Post mastectomy and axillary lymph node dissection, can't elevate her arm, and there was widening of the scapula. The injured nerve is long thoracic nerve, thoracodorsal, intercostobrachial, medial pectoral. It could be long thoracic nerve.
What is the diagnosis of this case?
See a breast.
No, I mean elevate the arm, can't elevate the arm, and there was a widening of scapula. What is the diagnosis?
The injured nerve is could be long thoracic nerve.
Yeah, I said can't elevate her arm, and there was widening of scapula. What does it mean? Widening of scapula. Please mean. Anyone? I discussed already this question.
Ma'am,
Ma'am,
is this serratus long thoracic nerve?
Wait,
It is related with long thoracic
intercostal
nerve.
intercosbrachia.
Serratus
ma'am,
anterior
the
injury.
wing of scapula is associated with the long thoracic nerve
Thoracic
because
nerve.
it causes
Long thoracic nerve injury.
Ma'am, it's
Yeah,
swinging
long
of scapula.
winging of scapula. Who is telling
and
this? Excellent. It's a winging
serratus
scapula.
inferior
Ma'am, I'm
of
telling.
scapula.
Yeah, excellent. It's the serrator. There's nothing. Just remember widening scapula. I just asked Dr. Muni, what is that? Dr. Muni always say, ma'am, it could be long thoracic nerve, excellent and serratus anterior injury. So winged scapula. Widening, because this is exam question. They ask two way. Either which nerve injured, neither what is the diagnosis. So one question, two diagnosis. First of all, it injured long thoracic nerve. Second diagnosis is widening of scapula. It's a wing scapula. Clear, Dr. Moni?
Yeah.
Okay, so long thoracic nerve question, if they ask that an latissimus dorsi, thoracodorsal nerve, there's intercostal brachial nerve, there's a median pectoral nerve, but our concern for our exam is that long thoracic nerve for the winging of the scapula. First question 6 will be discussed with me, Dr. Somia.
Yes, ma'am.
Yeah. Question 6 and question 7 both you will discuss it with question 6 and another doctor I'll discuss later question 7.
Okay, ma'am. 10 days postpartum breastfeeding lady complain of fever, chills, and swollen left breast. On examination, her left breast was engorged, cracked nipples, and there was a fluid containing the space. What is the most likely diagnosis? A. Breast abscess, and B. Fibroadenoma. Answer is breast abscess because it's a postpartum and patient is presenting with fever, chills, and swollen left breast.
Okay, okay. I'll tell this answer later. Question 7 will be discussed with me. Okay, I'll discuss later. Wait. So this question 7 will be discussed with me, Dr. Fatima Perry.
Yes, ma'am. A 22-year-old lactating mother presents with pain in her right breast. Examination confirms a 3 centimeter tender swelling with red and not overlying skin. Temperature. Which of the following is the most likely diagnosis? Maybe fibroadenoma.
How? Swelling, red. What are the clue? Pain, tenderness, skin color changes. Is there any clue that the fibroid in my skin color change, tenderness? I didn't hear.
Oh, no,
I
no,
didn't
no,
hear.
no, ma'am. No, ma'am. Red
Tenderness.
means it's red breast abscess.
It's the abscess. Okay, excellent. It's the abscess. Both question towards that. So see, Doctor forget the name. Sorry. First candidate discuss with me. Who is first candidate? Sorry, I forget the name. For question 6.
Dr. Somia.
Somia. Dr. Somia was discussing nicely that ma'am is a post-operative, postpartum, second fever, chill, swelling, left breast. So all goes towards the abscess. First of all, nicely catch the points. And she didn't go towards fibroid. Even there are lots of options. They'll misguide you. Postpartum fever just goes towards the abscess. Second way, this questions have now the same. J didn't give the fever option, but swelling along with the redness and tenderness, never ductal never fibroadenoma, never fibroadenosis. Because fibroadenoma, fibroadenosis, both are the benign, both never be tender. Just strongly remember, adenoma and adenosis both is benign and painless. Ductal ectasia must they'll give the nipple discharge presentation. So if I think 4 option, 3 option excluded, 1 option is breast abscess, right? Clear? All are the exam question I'm discussing today. Thank you. So question 8. Dr. Hira. If Dr. Hira okay to discuss with me, yeah.
Yes, ma'am. Young woman has painful breast lump with redness and tenderness. Vitals are given and show temperature 38.9 degrees centigrade. What will you do? A. Incision and drainage. B. Excision. C. FNA. Ma'am, incision and
First
drainage.
of all, tell me what happened. What is diagnosis? Then tell me.
Ma'am, it's a breast abscess.
Yeah, the breast abscess, and we have to do it's the incision and drainage, right? You answered.
Thank you, ma'am.
Okay. Dr. Reza Uruji. Question 9.
Yes, ma'am. Hi, ma'am.
Yeah.
31 years old female patient lactating complain of right breast thrombing pain with mild fever. Yeah, pain with mild fever on examination, signs of inflammation with tiny skin tenderness around 3 centimeter management. First of all, lactating, breastfeeding, and thrombing pain, and with mild fever. The fever is indicated inflammation, and there is a collection of tenderness and collection. Then it must be a abscess, and it needs to incision and drainage.
Okay, excellent, Dr. Reza. Excellent. You explain. Thank you, Dr. Reza. First of all, indication of percutaneous drainage size more than 5 centimeter. Dr. Reza's question is that it's a 3 and 3 centimeter, but it's a clinical scenario. It's abscess. So we have to do incision drainage because why? Dr. Reza's question, actually exam question. It's around 3 and 3 centimeters. It's not goes to the more than 5 centimeters, but there is a inflammation with thinning skin. This thinning skin, another indication for doing this percutaneous drainage. So we have to do the percutaneous drainage if there's a multiple abscess, if there's a thinning skin. So don't do wrong in exam. You are remembering size 5 centimeters, only 3 centimeters, but the thinning skin, inflammatory changes, gangrenous skin, even this question also recent exam question, there's a gangrenous skin over abscess, abscess already drained, already again abscess, frequent abscess, multiple time abscess, we have to do the percutaneous drainage. So this way indication of percutaneous drainage we have to remember. Thank you, Dr. Reza, you done well. Breast abscess incidence common organism is Staph aureus, and this diffuse inflammation due to streptococcus. Diffuse inflammation, it could be the postpartum. Common lactating female, especially in early lactation during weaning. This way they develop breast abscess. Pathology cellulitis, pre-supportive stage, abscess is a supportive stage. So drainage, we have to do the inflammatory. See, and we have to do the excluded. Is it cancer or not? Though cancer always painless, but it's inflammation, so we have to do the incision and drainage. Mastitis. Mastitis, milk engorgement, non-suppurative etiology, obstructive of lactiferous duct. So obstructive of lactiferous duct is mastitis. Mastitis presentation, fever due to milk production, and there is abrasion of the protein affected lobe. There is a lobes, and there is a lactiferous ducts there. There is tender, and there is a mastitis present. Complication can cause obstruction and abscess formation. So treatment, first of all, if it is abscess, we have to do the incision drainage. Before that, we have to prescribe antibiotic. Antibody regular breast evacuation by breast pump. So if a pregnant mom or breastfeeding mom or lactating mom, regular breast evacuation by breast mom, stop lactation burst continue. So another question, DHA question, recent question. This question I am discussing for recent recall. This question will be discussed with me, Dr. Rukutsia.
Yes, ma'am.
Yeah, your question, recent exam question, 35-year-old female come to your hospital with right-sided breast abscess, and you see it's a mastitis develop all over the right side, and she feed her baby by in both breast, right and left. What you will suggest to him for decrease the inflammation and improve the breast inflammation? Will you do stop bilateral breastfeeding, only right side stop, or no breastfeeding? Three option, exam question.
Ma'am, she should continue regular breast evacuation by breast pump of the right side in order to decrease the inflammation on the right side of the breast.
I said you can breast pump. I said the question was, will you continue breast milk bilaterally both breast, or you will change only right breast to left breast and you can't do any breastfeeding? So what is your answer?
Ma'am, continue breastfeeding.
No, it's not continue breastfeeding because right breast already engorged abscess. So we have to advise her that still decrease the inflammation, because we will give the safe antibiotic to decrease the inflammation. Only she will use left breast because right breast can't use for lactation. Another way, as you said, that pumping method, they didn't say anything. Just remember, for this case, this exam question, I will advise that you use your left breast for lactation, not right breast for lactation. Okay, question was for
Okay.
lactation part. What you will advise? For lactation, I have to advise only use left breast, not right one. Okay, exam question.
Okay.
Yeah. Okay, this question 11 will be discussed with me, doctor. In my platform, there is a Dr. Umer. It's a Maha Umer, right?
Yes, ma'am.
Yeah, Mr. Maha Umer, discuss. It's 11.
A 37-year-old complained of right breast lump for 3 months. She has family history of breast cancer. Physical examination confirmed a hard lump in upper outer quadrant of right breast with ill-defined edge and skin teething and no palpable auxiliary lymph node. Which of the following is the most appropriate next step in management? A. MRI breast. B. Core needle biopsy. C. Bilateral mammography. D. Fine needle aspiration cytology. Ma'am, his family history of breast cancer. Hard lump. Management. Ma'am, hard lump. Skin teeth. Core needle biopsy option B. No, ma'am. D. Fine FNAC. It's a hard lump in upper outer quadrant of right breast.
Okay, Mehar Omar, okay, you will wait. This question will be discussed with me, Dr. Nandini.
Yes, ma'am.
Hmm. Read this question.
Ma'am, I think the answer will be like MRI breast because she is having a family history of breast cancer, which is an indication for the MRI breast.
Okay. So Dr. Nandini and Dr. Maha both will be on waiting. Dr. Priscilla.
Yes, ma'am.
What is the
I
answer?
think it's core needle biopsy.
Okay. So 3 candidates missing. So same wrong. Why? First of all, right breast lump, 3 months. She has a family history of breast cancer. So your question, right breast lump, family history positive, and lump is hard. Next, not definitive. I always my every candidate tell always remember the question. Next is not biopsy. Next is mammography, bilateral. First of all, I have to ensure is it only right breast or both breast? Because if it is malignancy, it will be the spread or it could be the bilateral malignancy, but we don't know. Only they say it's your information. You have to be safe physician everywhere. So first of all, I have to do bilateral mammogram because they didn't say next best, next appropriate. So they said next step in your management. Next, I have to confirm by doing bilateral mammography. Then I have to do the core biopsy. Like that way, I have to do proceed. Clear?
Yes, ma'am.
Yes,
Even
ma'am.
because
Yes,
these
ma'am.
are the steps. Even if actually this only one, if you do this, it's a 1 month will be gone. Because if you say it's the next step, they didn't say next definitive, what is appropriate, what is the definitive for this, because definitive means I have to do biopsy. Next means I have to exclude is only right breast or left breast is okay, right breast, okay, is the right breast safe or not. So I have to maintain safety of the patient. The answer is a bilateral mammography.
Okay, ma'am.
Okay. Question 12, Moshumi, Dr. Moshumi.
Yes, ma'am.
This question just discussed before that. Before I'm starting this discussion, question 12. First, my breast topics. What I was started my PDF session. It was not recorded, but don't worry, I'll give those all. But who missed my recording? This enough. This question was revision, okay? Because all I discuss on my PDF, just I'm now discussing the question. So based all information here, there's nothing to be worried. So question, Dr. Moshumi, question 12.
Yes, ma'am. BSC who has bilateral dense breast. is 34 years old. Best test for screening.
Think and no need to be hurry because we are here. There's nothing to be hurry. We have to keep concerned that what they said and what I'll do because this question was discussed. Okay.
As there is James Brest and he is 34 years. Ultrasound.
BRCA2 positive, BRCA2 positive has bilateral dense breast and age 34. BRCA2 positive mean what, dear? What does it mean? BRCA positive. What does it mean? And already bilateral dense breast means it is maybe the ultrasound finding, but there is a recall. Just remember, bilateral dense breast present. I telling there's a bilateral dense breast. It is maybe the US finding or it may be the anyway mammography finding. So BRCA2 present positive, bilateral dense breast positive, and age is 34 years. What you will do? Remember again. MRI. We have to do MRI, okay? Because it's a primary breast cancer. First of all, we have to do the MRI because occult primary breast cancer concern, we have to do MRI because it's a diagnostic purpose, even if need new adjuvant chemotherapy for consideration. First indication of breast cancer, they say dense opacity. For somehow it was the mammography finding. I already discussed in mammography because in ultrasound dense breast must it will not be so significant, and they didn't say any clue is it mammography finding or ultrasound finding. And BRCA to enough for discuss, enough for thinking for MRI for starting new adjuvant chemotherapy. Another way, Dr. Moshumi say BRCA mutation 25 to 29, age is 34, first degree relative BRCA or BRCA carrier. So patient is BRCA positive, it's not carrier, it's itself positive, and it's a chest and 10 to 30 years old. Anything is another indication. Just I have to remember 3 indication. If BRCA mutation 25 to 29, first degree relative positive or carrier or self carrier or radiation anyway in 10 to 30 years. So we have to choose, Dr. Moshumi, what? We have to choose? MRI, okay? Yeah. Thank you, Dr. Dr. Nipuni is here. If Dr. Nipuni is not here, this question will be discussed with Dr. Priya.
Yes, ma'am.
Question 30.
25 years old female patient complain of painless lump, hypoechoic 1 into 2 centimeter, mouse movement. Next. A. Reassurance. B. Lumpectomy. C. Excisional biopsy. D. Analgesia. E. True cut biopsy.
So first of all, Dr. Priya, I want to hear that what is your thinking? What may be?
I think the diagnosis would be fibroadenoma, ma'am.
Okay.
And for fibroadenoma, we have to do lumpectomy, ma'am. Option B.
Without anything, okay. I'll discuss later. Nothing to worry. Okay. Question 14 will be discussed with me, Dr. Monia Jaman. Is here? Okay. Dr. Monia is on Hari. Dr. Priya is keep with me. Dr. Nipuni is here. Okay, Dr. Tamanna.
Yes, ma'am.
Yeah. Question 14.
Question 14. Female had mass on the left side, painless and movable. Increase, slow growth, no affected by menstrual cycle. A. Fat cyst. B. Fibroadenoma. I think B, fibroadenoma.
Okay, due to painless and movable, and it's a
Yes, ma'am.
slow growth. Okay, and Dr.
Yes.
Priya's question was painless lump hypoegy. Also, it's a fibroadenoma, but Dr. Priya's was what is the movement next? Next, I can't do lumpectomy, Dr. Priya. Next is
Yes.
we have to do ensure what is that benign or malignant. You are a doctor, painless now. You are not confident. Is it malignancy or benign? You are not confident. You are saying it's a
Yes.
penalized. It could be malignant. It could be anyway. It's a file, whatever the thing. So I have to do what? I have to do
Well,
true cut biopsy.
secret biopsy. Yes, ma'am.
Okay.
Yes, ma'am. I understand.
Next best, just remember, my dear candidates. Oh, every day I'm telling every day I'm telling one word. Just read the question next, because this is the tricky. This way they will do wrong question answer. So, true cut biopsy is the answer, and the another Dr. Taharim Tahmina as the answer is a fibroadenoma. Fibroadenoma question. Fibroadenoma is the most common breast mass of young female. Breast, most common. It is the most common benign tumor, painless, small. It could be tender, not tender, commonly not tender, rounded, could be firm. So, firm. If you remember this firm, no, it never be is adenoma. No, firm it could be. Some circumscribed, smooth, small cell surface. There's the features, lumps, freely mobile lump, and breast mouse like a mouse. It is movable. So freely mobile lump, breast mouse like presentation. So on mammography, so see, my dear candidates, for cancer, there will be the hypoequic shadow. There's a cluster shadow, but there is a popcorn lesion. In adenoma, they see this is the popcorn-like lesion after excision of the adenoma. So, for the adenoma, we have the excision indication. When we will do, Dr. Priya just directly telling that I have to do lumpectomy. No, it's not lumpectomy. The word is excision. Just excise the lump when, if more than 3 centimeter, my dear candidate, this indication very recommended strongly. You have to remember, if it is more than 3 centimeter, if patient is symptomatic, if age more than 35, increased cellularity on biopsy, anxiety of patient itself one that, ma'am, please do exercise, please do it, but it's still not on our criteria for excision, but patient is very concerned for excision. So it's a patient anxiety, recurrently having this adenoma. So these are the indication of excision. No, never sell this lumpectomy, never. Why lumpectomy, my dear? It's excision, because lumpectomy is the best lumpectomy, is the best mastectomy. What do you mean? Just remember this, excise the mass only. If more than 3 centimeters, symptomatic, is mobile, is the hazardous of the life. If age is the very increased cellularity, goes towards the malignancy. So we have to do the excision. Age more than 35, ultrasound mammography, it according to the presentation. But remember, always we do mammography if there is a family history positive. In case of benign condition, we can do ultrasound only. In case of malignancy chance or acellular atypical malignancy, we have to do core biopsy. Benign lesion, we have to keep repeating this mammography or ultrasound 3 monthly. Lesion not seen on horizontal patient desire, we have to, like, means a patient have a mass, but patient desire do exercise my mass, so we have to do exercise. Acellular atypical malignancy, do exercise. So first of all, when we will do mammography, when we will do ultrasonography, we have to remember, if below 35, but there is a mass, so desire, there is observation, you can do observation. If there is a desire for the excision, you can do excision. If observation, we can do ultrasound. If ultrasound reveals atypical malignancy, we have to do the biopsy. If ultrasound reveal with core biopsy atypical malignancy, so according to the, these are the steps we have to follow regarding the age and presentation. Question 16 will be discussed with me, Dr. Badhon. Actually, Dr. Badhon name, but I may not the name of the, what is your actual name, my dear? So Badhon or Aniketa?
Ma'am, yes. My actual name is Dr. Badhan, but it was my Gmail ID. That's why another name was
in which name I know you actually. That's the that is I am
Dr.
asking.
Badhan. Yes, ma'am. It's
Dr.
my
Bhatt.
actual name.
Okay, okay. The question 16. Okay.
45 years old female with breast lump, core needle biopsy show stroma cells with no mets. The most appropriate management is lumpectomy with axillary lymph node dissection, modified radical mastectomy, wide local excision, and no axillary dissection. Repeat core needle biopsy. 45 years and breast lump, core needle biopsy, stroma cell, no metastasis. Ma'am, I think patient is already 45 years old age patient, and core needles show that core needle biopsy is showing stroma cells, but no metastasis. So I most appropriate management, I will go for wide local excision and no axillary dissection.
Excellent, excellent. Okay, Dr. Badhan, excellent done. Thank you, Dr. Badhan.
Thank you.
Excellent. I'll discuss later. So, next question will be discussed with me, Dr. Priscilla.
Yes, ma'am. Patient presented with 4 cm tumor in her breast. Turns out it was phylloides. What is your treatment? So phylloides is aggressive tumor, so white tumor excision.
So, what tumor excision? Okay, thank you, Dr.
Yes.
Priscilla, first,
Thank
excellent done. Both candidates, Dr. Badhan done
Thank
excellent. That is a breast lump, core, there's a stroma present, there's no lumpectomy. Though already core needle biopsy showed there's a stroma, I can do only wide local excision, no axillary dissection need because there's no metastasis, there's no need to remember the modified radical mastectomy, there's nothing repeated core needle biopsy, enough. It's excellent presentation. Got Dr. Priscilla's quest was there's a filers present. So only filers present, we have to do only wide tumor excision. These are the exam question. Just remember, if this performance same as exam, inshallah all will do pass in one item. There's nothing to be confused. So question 18 will be discussed with me, Dr. If Dr. Vizin is here, Monia Jaman. Okay. So from the first, Dr. Donilda. Yes, so from my this first circle was ended. So Dr. Donilda, do perform this question.
Yes, ma'am. A 45-year-old female presents with 12 centimeter diameter and increasing in size. Examination reveals a mass with a firm and rubbery. Mammogram shows rounded dense mass. Biopsy reveals non-epithelial lesion with highly cellular stroma, polychromisia, and high mitotic figures. What is the most appropriate further management? I feel it's mastectomy.
Okay. What are the clue here for the decision? For the decision, what are the clue?
It's a round dense mass and already
Increasing in
by
size.
yeah, increasing in size and highly cellular stroma, and the biopsy shows a non-epithelial lesion. It's high
Yeah.
mitotic figure, so everything goes 45-year female also. So that also counts age. So everything we calculate.
Goes
So it's
towards the
mastectomy.
yeah, excellent. Sir, mastectomy, excellent, and Dr. Donilda, thank you. So
Thank you.
first of all, first of all, this is the filers, and age is 45. So age is the 14, 15, and the fast growing. So Dr. Donilda's case was also fast growing, and this filers and there is stromal on biopsy. So treatment. Wide local excision when simple mastectomy. Local excision if there is a 1 centimeter margin, there is no need dissection, and if there is a prevent recurrence, so we can do initially. But this presentation age is the factor, firm cellularity, this structure, infiltration, whole breast when infiltrate. This is Dr. Donilda's case. In case of whole infiltration of the tumor in the breast, so we have to do the mastectomy. There's Dr. Donald Lysis said it's a 12 centimeter diameter. It's 12, it's not 1 or 2. It's 12 centimeter, increasing in size, means fast growing, mass is firm. So when we will do WLE wide local, when we will do mastectomy, we have to remember Dr. Donald Lysis said it's a fast growing along with this reveal mass is firm, rubbery, rounded, dense mass along with this non-epithelial lesion. There's a high cellular stroma and there's a high mitotic figure. All goes to polychromation. That means it's a diffuse. This tumor is a diffuse in nature. It's not single. It's not so simple. So one knot is 1 centimeter. No node disease. It's not like that. So we can do WLE. But if it is diffuse and it's a diffuse type, so we have to do the simple mastectomy. Pilus tumor. Already for initial evaluation, they will give the age, life history, suggestive of adenoma or the mass or rapid growth or slow growth, all they will give the clue. But for core needle biopsy, if fibroadenoma, we can do close follow-up if it is fibroadenoma. If pilus tumor includes benign, if filers includes benign, borderline, malignant. So filers, if it's a kindly mute doctors. Okay. If filers, if it is a wide local excision without axial staging, if it is benign, borderline, and malignant. So this way we have to remember filers, but it is benign or borderline malignancy, we can do only WLE without axial staging. But regarding the doctor's Dorilla's case, there's invasive. Okay. So breast cancer, invasive. So we have to do the mastectomy. So if fibroepithelial lesion, intradermal pathology, excisional biopsy, all goes towards the pathology present, borderline or malignant lesion. If 5 centimeter stromal greater than, so tissue sarcoma staging we have to do. Regarding the, if it is the Dr. Darren's case was 12 centimeter. If it is more than 4 centimeter, there's a staging we have to do. This algorithm staging was, so we have to do this mastectomy. Okay. So they'll give many clue regarding this, that adenoma or is it diffuse or it is single, only 1 centimeter, 2 centimeter. So it's a single. I was discussed with another question. Maybe it's a Dr. Priscilla that only we have to do WLE. This question was we have to do the WLE. This is the filer. The turnout filer is only 4 centimeter, but turnout it was filer. So we didn't do mastectomy here. We have to do this WLE. Why tumor excision? Because this case question 17 and question 18 case was use difference. So there's a presentation. Okay. Actually, I'm giving frequently 17 and 18 question emphasis because this question common question exam. When I will do wide local excision, when we have to do mastectomy, though I'll give all PDF, just remember strong point. Okay. Question 19 and question 22 candidates. Question 19 will be discussed with me, Dr. Hira.
The female presented to the clinic with non-tender lump in the right breast.
Ma'am. Question 19, a female presented to the clinic with non-tender lump in the right breast. Her mother was diagnosed with cancer. Biopsy was taken, shows atypical ductal hyperplasia. Prevention, simple mastectomy, follow up in 6 months, wide local excision.
Okay. If you face any difficulty to discuss, no issue. Okay, Dr. Hira may be on travel. So the question 19 and question 20, the both question I want to discuss. First of all, Dr. 19 will be discussed with Dr. Nipuni is here. Nipuni. Okay, maybe she's on duty. Dr. Fatima, only Fatima.
Yes, ma'am.
Yeah. If you are able to talk with me, you can talk with me.
Yes, ma'am. I can talk to you.
Yeah. Question 19.
A female presented to the clinic with non-tender lump in the right breast. Her mother was diagnosed with cancer. Biopsy was taken, showed atypical duct hyperplasia. A. Chemo prevention. B. Simple mastectomy. C. Follow-up in 6 months. D. Wide local excision. So, ma'am, it would be D with wide local excision.
Wide local excision, right? Your answer?
Yes, ma'am.
Atypical ductal hyperplasia, we have to do WLE, right? Only clinical scenario for exam, my DHA heart candidates. Wide local excision, we have to do in atypical ductal hyperplasia. Okay, thank you, doctor. Question 20 will be discussed with me, Dr. Sabajison. Question 20.
Intraductal hyperplasia in patient with the breast cancer family history. Intraductal hyperplasia, A. Simple mastectomy, wire excision, B. C. Radical mastectomy, and D. Preventive chemo. It was C, ma'am. Radical mastectomy. Also was
Interductal
C.
hyperplasia. Just I discussed with Dr. Fatima that atypical ductal hyperplasia or interductal hyperplasia. So why radical? What is the cause radical? Cause the only duct involved, doctor. Dear doctor, only duct involved means we have to do only duct. Intraductal hyperplasia. We have to do only one things. There is no function for mastectomy or radical mastectomy, nothing. Only ductal means we have to do
wire excision.
wire excision. My dear candidate, just remember my MOH heart candidate, just remember only one point ductal means WLE. That's it. Simple mastectomy, wide modified radical excision. This is only for the malignancies, the huge, there's a pilous tumor, diffuse in characteristic. I already discussed Dr. Donilda, Dr. Saba. Just remember, interductal means I have to do wide local excision. Clear?
Yeah, yes, ma'am.
Okay. Neat. So don't do wrong because this is the paid exam question. Can't do wrong because this is the paid same to same they ask. So we have to remember that what I'll do. Interductal papilloma, interductal hyperplasia, whatever interductal, I have to do WLE. If there's any mass, it is aggressive in nature, invasive in nature, diffuse characteristic, can do any radical modified or radical. It goes towards my presentation. Always see the presentation. Okay.
Okay, ma'am.
So these two questions will be discussed by one candidate because this question I already discussed strongly in my PDF lecture or didn't record it. That's why I am solving this question with my candidates. These two questions will be discussed with me, Dr. It's a Dr. It's a Reza Oruzi.
Hi, ma'am.
Yeah.
Strongest risk factor for breast cancer, as you mentioned, first is mutation BRCA, and after that is age.
So, what is question 21 answer and what is question 22 answer?
21 is A, and 20, the most risk factor for breast cancer, when there is not BRC, then the possible answer will be A, 2A.
Excellent. Yeah, excellent, Dr. Orozi. This is the point that we are hearing my session. Because first of all, strongest risk factor, I said that strongest and most common BRCA is the strongest risk factor. I'm telling same things because my some sessions didn't record it, that's why, but same PDF I already discussed. ACE second, most common is the ACE. First of all, BRCA, this is the exam paid question. They didn't even change, same to same exam question. So BRCA is the strongest risk factor, 50-year story of the breast cancer. This causology we can remember later, but regarding the hormone replacement therapy and menopausal women, non-fertility, childbirth after age 30, so these are the risk factor for the breast cancer. But this question was answer will be that if it is they ask this the strongest and most common, as usual we have to see what they said. If most common factor they say stay is the BRCA, answer will be the BRCA first. If there is no BRCA answer will be the A's. Okay. So screening for the BRCA, mammogram and MRI yearly. So why? BRCA positive, family history positive, BRCA positive. So we have to do mammogram and MRI yearly from 25 years. BRCA carrier, BRC strongly positive, pelvic examination, pelvic ultrasonogram from the cause it is associated with ovarian cancer. BRC is strongly associated with ovarian cancer, so we have to do yearly pelvic ultrasound and pelvic examination. CA 125 to find out any malignancy of the ovaries. So we have to do 25 year from the 25 year BRC screening. So this is the higher topics for the exam. Question 23 will discuss with me. Dr. Kushori.
A 50 years old female patient complains erythema and edema of left breast treated with antibiotic but not improved. The most appropriate next step. She is having erythema and edema. She's 50 years old already. She's more than 50. She's 50 years
So
old.
what are the factor? And you have to remember, tell me, ma'am, these are the thing I am thinking this way.
Change antibiotic is not possible. MRM means that is a mammogram, ma'am?
No, MRM means modified radical mastectomy. MRM means
Okay.
modified radical mastectomy, sorry. So your option is radiotherapy, biopsy including skin. So see, your patient erythema, edema, left breast, right?
Yes.
And you are giving antibiotic, but there is not improvement. Will you do modified radical mastectomy, changes antibiotic, or biopsy or radiotherapy? What you will do, doctor?
Antibiotic is no, ma'am. Radiotherapy is also not. B and C. Is it B, ma'am?
It is B. First of all, my dear, erythema and edema, but it doesn't mean that it could be any mass lesion, infective. Okay, mass but infective. Edema. It is indirect question, DHA question, indirect DHA question, because they only said erythema, edema, already on antibiotic but not resolving. It could be the filers, it could be the any type of malignancy, but it is not resolving with antibiotic. Mean I have to do biopsy, because there is no infective picture like it's a breast, is a abscess, tenderness. There is nothing, only tenderness. So I can't think it's abscess, but if it is abscess, it will resolve with antibiotic. It is not modified radical mastectomy, because there is nothing a clue for modified radical mastectomy. Changes antibiotic don't know, because already I am giving antibiotic. There's no role of changes antibiotic. Radiotherapy no. So I have to do biopsy with the skin, because if I do biopsy with the skin, it will reveal what is the ongoing the changes of the breast. Okay, doctor. Though you write, but you have to understand this way. Clear, Dr. Kishori?
Yes, ma'am.
Okay, so biopsy into skin is the answer. Question 24 will be, this is the not good question, it's a hard question. This question I want to discuss with Dr. This question will be discussed with me, Dr. Shamragre Priya. Okay.
Yes, ma'am.
Question 24.
55-year-old female patient presents to the clinic, complains of VP scaly lesion on her right nipple. Mammo and ultrasound shows no mass. Wedge biopsy, it shows Paget cells. Next. Is it A, simple mastectomy, or B, simple mastectomy including nipple areolar complex plus SLND, a lumpectomy with ALND, or ectoty?
SLNB means what? Sentinel lymph node biopsy.
Sentinel lymph node
ALND,
biopsy.
yeah, axillary lymph node dissection. ALND means. I am again telling the in the mix because this is short time. That's the ALND means axillary lymph node dissection. So what are the picture that female patient come to your hospital, scaly lesion, weepy, okay, and right nipple, mammo and ultrasound. There's no mass, but waist biopsy showed Paget cells there, right? So Paget cell there means, but there's nothing, no mass. So that's it. What is the excluding method there? How I can reach my diagnosis and my answer? How?
Ma'am, we can exclude A and B. We no need to do mastectomy, ma'am, because there is no mass.
Okay. Then
Biopsy shows Paget's cells, ma'am. So I think it's Paget's disease.
mhm. First of all, this is the Pagers. Okay.
Yes,
This is the
yes.
Pagers, but I have to do, there's no role of the lumpectomy or axillary lymph node dissection because it's only Pagers, it's not malignancy. There's no role of radiation therapy. D option. So
Yes.
C, D excluded, either A or B, right? So
Yes,
for
ma'am.
A or B, if I think in pages, I'm explaining, answer is the B, no need to be worry. Answer is the B, simple mastectomy including nipple areolar complex and sentinel lymph node biopsy cause in pages, scaly weepy skin lesion there, Dr. Priya, scaly
Yes, ma'am.
weepy skin lesion. So my answer is that simple mastectomy with sentinel lymph node biopsy cause there's a Paget cell. So I have to identify what about the sentinel node by doing the biopsy. Modified radical mastectomy is not first we will do here because there is no option in modified radical mastectomy. In pages, exam question, they keep modified radical mastectomy. Answer is the modified radical mastectomy. But if not modified radical mastectomy in option, I have to mark nipple areolar complex with simple mastectomy and lymph node biopsy. Clear?
Yes, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
So answer actually they give modified radical mastectomy, but is there is no option, so you have to do simple mastectomy with modified simple mastectomy with sentinel lymph node biopsy, and there is along with this we have to do sentinel lymph node biopsy. So eczema, yeah, Paget's disease and this eczema question, Paget's always unilateral, eczema always bilateral. Cause why eczema? There is a difference. Cause there is a weepy lesion, scaly lesion. No need to be confused with eczema. There's a weepy scaly lesion. It could be eczema, but when they say there's a Paget cell there, Paget cell there means it's a Paget disease confirmed. So age is the older patient. What is our age patient? Is there 55? So it's the elderly patient ongoing. So older patient Paget's, eczema younger patient. So age another important role of diagnosis of Paget's because they ask two way, either what is the management or what is the diagnosis if they didn't give the Paget cell. So if they don't give the Paget cell but unilateral, there's a mass scaly lesion there, but there's no itchy, no vesicles, only nipple are destructive. Okay, so mammographic changes there, so all goes towards the especially strong information, the age, nipple destruction, mammographic change, all goes towards not malignancy, all goes towards the Paget's. If Paget's cell there is excellent, they give the strong clue, but if they didn't give this clue, I have to choose this mastectomy with nipple dissection. For the eczema, no lump, but Paget's there's a lump, there's a vesicle and pustules in the eczema, there's a normal mammogram in eczema. So that is the way we have to do differentiate each other. Question 25 will be discussed with me, Dr. Sajma.
Yes, ma'am.
If Dr. Sajma able to talk, you can talk, neither, no issue.
Am I?
Yeah.
You did fibroadenoma excision for one of your patients and send it to histopathology. Then histopathology reported lobular carcinoma in situ with free margins. Uh, What is your management? Bilateral prophylactic mastectomy, chemotherapy, radiotherapy, reoperate with safe margin. Uh, Answer is A, bilateral prophylactic mastectomy.
Excellent. Do you know why A? Though excellent done, I really is excellent. Do you know the indication? Lobular carcinoma.
Lobular
Tell me.
carcinoma, high chances of mets. So we'll do
High
prophylactic.
chance of mass. Excellent. High chance of mass. Excellent point. Lobular carcinoma, high chance of mass. We have to do bilateral prophylactic mastectomy, right? So this way, Dr. Sasma excellent done that lobular carcinoma, there is a high chance of malignancy and metastasis. So we have to do the prophylactic mastectomy. First of all, treatment options are lobular carcinoma in situ. Follow up if initially, but prophylactic bilateral subcutaneous mastectomy is always definitive management. Always definitive management. Even medical management, if they ask, we have to choose raloxifene or tamoxifen as to decrease the changes of the lesion. They ask what is the definitive as Dr. Sasma's question. So there is no medical therapy option here. Initially, they say, what is your management? So what is my management? Is there's no medical management, there's no observation option. So I have to do bilateral prophylactic mastectomy, definitive management. So they ask indirectly. But if they ask what is your medical management, raloxifene and tamoxifen, we have to remember. And the criteria of the lobular carcinoma, no classification is if developed cancer, ductal cancer. So these are the criteria lobular carcinoma in situ. So we have to remember this way. If develop cancer ductal, no need negative margin. So no need negative margin means no pre-malignant, but markers develop breast cancer. Always this lobular carcinoma in situ goes toward breast cancer. Okay, Dr. Sajma done well, very well. Question 20, this is very important exam question. This question will be discussed with me, Dr. It's a Maha Umar.
Yes, ma'am.
Mhm.
35 or 45-year-old pregnant present with left side breast mass. Swim mobile, what to do next?
First of all, I am telling doctor two question here. I am telling it's a 35. What you will do? And second question, it's a 45. What you will do?
Ma'am, if age is 35, then we should proceed with bilateral ultrasound, and if age is 45, then we should go for bilateral mammogram.
Okay, excellent done. So both question in one question. So this is the way we have to think. Thank you, doctor. This is the answer. You're correct. Second question, doctor, is will be discussed with me, Dr. Kutsia.
Yes, ma'am. 55-year woman, no family history of breast cancer, mammogram normal, went to do next mammogram 3 yearly. It's B 2 yearly.
Why? Cause? What are the cause?
Because she is 65-year woman. With no family history of breast cancer, so just for screening.
Okay, so first of all, strong clue, there is no family history of breast cancer. Okay, so we have to do 2 yearly screening. Thank you, doctor. So we have to do that with no family history of breast cancer. We have to do 2 yearly. This is the exam question. So we have to remember the risk factor. If it is risk annually, we can do from the 45 years. If there's no risk, 2 yearly we have to do. This explanation can do later. So case of breast lesion, Viras code 3, I discussed just before. Viras code 3, we have to do follow 6 monthly. If it is Viras core 4, we have to do core needle biopsy. If Viras 4, same as needle core biopsy. This is the exam question. And Viras score I already discussed in my PDF that Viras 4-5 for the biopsy. If cyst malignancy, if it is 2, it's a benign, you have to keep follow up 6 monthly. Question 33, Dr. Moshumi.
Yes, ma'am. 26 years old female with multiple master cells in the left breast. Breast tender around period, US pro, multiple small cystic lesion and two solid muscles. Uh, Fibrocystic disease.
So what are the clues for fibrocystic?
First, you finding with so small cystic lesion and multiple small muscles, non and tender around period.
Okay, excellent, Dr. Moshumi. It's a fibrocystic. First of all, you got this point that is the point actually here, that multiple muscles felt in the left braces, gas tender around the prior. So gas tender, this is the point. Dr. Moshumi nicely said, though didn't confuse that during the prior it goes tender. It's a fibrocystic changes multiple small cystic ghosts, and around the prior it's a fibrocystic changes. Nice done, Dr. Moshumi. Excellent. Only 35 question I'll discuss with Dr. It's a Dr. Priscilla. 35
Yes.
question.
30. Breastfeeding mom complains of unilateral inverted nipple. When she tried to adjust the nipple, it slid horizontally. What's the diagnosis? So unilateral inverted nipple, I think it's a
Unilateral
mom.
inverted nipple.
Since there's no nipple discharge, I'm thinking it's malignancy. Don't know.
Unilateral inverted nipple, my dear. Unilateral inverted nipple. This is only one clue. Only one clue for having ductal ectasia. Only one clue. Clean card. Okay. Even same way they ask in the exam. Just remember, only inverted people nipple means it's a ductal ectasia. Okay.
All right, ma'am.
So later I'll discuss two questions after my session. Just a few important questions. This topics I want to discuss shortly. The whose topics was missed from beginning. It was already discussed from the question. So the recording first 15 minutes was not recorded. So no need to be already all discussed regarding the missing. Pilus tumors already are discussed regarding the hemorrhagic no nodal metastasis trauma tumor on biopsy. So when we will do the WLE, when simple mastectomy, if there is interepithelial lesion, Dr. Nodal nicely explained nicely regarding this wide local excision, only 1 centimeter margin, no lymph node. So there is a simple mastectomy. So breast mass, fibroadenoma, giant juvenile fibroadenoma, fibrocystic change, breast abscess. This way the presentation group. So fibroadenoma group A is younger, for the fibrocystic 30 to 40, and breast abscess mostly lactating women. Presentation will be like that, with smooth, well circumscribed in the adenoma. For the fibrocystic associated with bilateral cystic, Dr. Moshu nicely done this fibrocystic varies with menstrual cycle. This is a strong point. Abscess goes towards the pain, erythematous, and warmth. These are the strong clue for diagnosis. This way they ask in the exam. Interductal papilloma always associated with bloody discharge. Okay, so 20 to 40 years of age group. Cis, just shortly I'm describing theoretical. So fat necrosis from mass erythema, bruising of skin. This is the fat necrosis, history of the trauma. So history of the trauma, patient come to your hospital with firm mass in the breast, erythema, bruising, history of trauma. It goes toward the fat necrosis. Another cyst along with the prior tenderness, it goes to the fibrocystic breast changes. Ductal carcinoma in situ, I already discussed 3 questions. Nicely done. My candidates, really. Ductal carcinoma in situ, simple mastectomy with sentinel lymph node biopsy, lumpectomy, 2 millimeter margin, or X-radiation if there is axillary lymph node dissection or sentinel lymph node biopsy. No, there's no significance, so we have to do the X-radiation. Just remember, hormonal if optional. So if definitive for ductal carcinoma in situ, simple mastectomy with sentinel lymph node biopsy. This hormonal tamoxifen and raloxifene lumpectomy, actually from myself, I don't recommend to remember, cause just remember, if margins save, we have to save the margin because it goes toward the breast cancer. So you have to do this first one, simple mastectomy with sentinel lymph node biopsy. So simple mastectomy with sentinel node biopsy already I discussed. If multicenter, multifocal, patient preference, male inability to get margin despite resection. Inability, because this point they give, inability to get margin despite resection, we have to do simple mastectomy with sentinel lymph node biopsy. So lobular carcinoma, ductal carcinoma, tamoxifen already same as well. Ductal and lobular carcinoma, there's just remember all the cancer. So ductal carcinoma, lobular carcinoma structure involve ducts and lobules. Cancer goes towards ipsilateral breast and either one breast or bilateral lobular. Laterally or bilateral lobular, so lobular more dangerous than ductal. Number of site energy multicenter. So ductal lobular is more dangerous than, more laterally than ductal. Invasive ductal carcinoma, screening of the breast, just shortly I already discussed that we have to start the mammography from the 45, then 45 to 54 annually, from the 55 to yearly. High risk case, we have to start according to the first degree relative positive or 25 years, we have to do screening yearly. Staging of the breast cancer, my dear, just stage 2A, 3B, and 3A. Just remember, lymph node cause. They asked the staging recently. MOH candidate staging. Remember, stage 2B lymph node and the primary tumor size. When stage 2B, just remember, or just look over it. 2A, 2B, 3A, 3B. That's it. More than 20 when lymph node association metastasis commonly. TNM staging. Okay, TNM lymph node. When stages are there, just remember. Stage 1, stage 2, what we do? We can do mastectomy or extra radiation. If axilla involved, we can do sentinel lymph node biopsy with axillary lymph node dissection if axilla involved. So no need metastasis workup in stage 1. In stage post-operative radiotherapy indication, when post-operative, we already done mastectomy, but radiotherapy indication if stage 3 tumor size more than 5, close margin involvement extensive, and there is a lymph node biopsy positive. Just remember this one strongly. Post operative radiotherapy indication if tumor size more than 5 centimeter, if close margin involvement. Okay. Tamoxifen, raloxifene indication, they already given premenopausal, postmenopausal, raloxifene, aromatase inhibitor, okay, Herceptin, HR2 inhibitor, positive most. Just remember only, that's not so important for the exam. So I already discussed every higher topics today. So anyone have any question from the breast? Anything to know? Already all discussed regarding the ductal carcinoma in situ, lobular carcinoma in situ, and invasive ductal carcinoma, hard, immovable, hard, irregular shape, border, all already. This PDF might need download, take time, but it all will be the posted later in the group along with the session. Management, if stage 1 and 2, early invasive, local advanced stage 3, stage 4 in case of metastatic, this classification of the management. This lumpectomy, radiotherapy, just remember stage 1, 2, 3, 4. Chemotherapy, radiotherapy, agonal stage 4 and stage 3 are a neoadjuvant chemotherapy. Very important for exam. Paget's disease already discussed with Dr. Priya or maybe something. Paget's disease we have to do modified radical osteotomy or simple mastectomy with sentinel lymph node biopsy. No need axial lymph node dissection if clinically positive. But if clinically positive, if we have to do axial lymph node biopsy, and if biopsy present as a Paget cell. Okay. Tumor lysis is associated with the hematology. So tumor lysis I'll discuss later. So today I discuss every higher topics for the breast related question, and I'll post those question. The mock will be tomorrow or I'll post later today. So one have any question from the breast? Next session will be day after tomorrow. Okay. Okay. So thank you, my everyone candidates. I'm ending my session. Okay. Assalamualaikum to all. Do practice
Yeah,
and
thank
read.
you, ma'am.
Yeah.
Thank you,
Thank
ma'am.
you,
Yeah.
ma'am.
Assalamualaikum. Yeah.
Thank you.
Okay.
Thank you,
Yeah.
ma'am.
Assalamualaikum.